Hi, my friends. Welcome to our presentation on hemophilia. I'm going to be doing the introduction and the pathophysiology process with my friends the lemur, and later on we will have a presentation that includes a puppy and a red panda and some other funny animals for you guys. So let's get started on hemophilia. Hemophilia is a group of severe hereditary hemorrhagic disorders that alter blood coagulation. Due to missing proteins in the clotting cascade, patients diagnosed with hemophilia have a delayed clotting period resulting in excessive bleeding or oozing of blood after minor trauma or even simultaneously. Hemophilia is categorized into three groups. You've got hemophilia A, B, and C. Hemophilia A is the most common. Hemophilia B is slightly less common, and then hemophilia C is the most rare. Each of these is caused by a different deficiency of a clotting factor. Hemophilia A is associated with factor 8 deficiency. Hemophilia B is associated with a factor 9 clotting deficiency, and then hemophilia C is associated with a factor 11 clotting deficiency. The biggest risk factor for patients with hemophilia is family members who also have hemophilia. Males are genetically more predisposed to having hemophilia than women. Moving on to the pathophysiology. The blood clot formation, as we all learned, if you have to take Professor Meyer's class, involves the activation of two pathways. There's the intrinsic pathway, and the extrinsic pathway, or the tissue factor pathway and the contact pathway. Both pathways consist of a cascaded enzyme activations that ultimately lead to the formation of a clot. The extrinsic pathway is triggered by exposure of tissue factors as well as disruption in the endothelium of the blood vessel. And then the tissue factor binds the activated version of all of these clotting proteins. Both of these pathways merge, and the production of factor XA converts prothrombin to thrombin. Thrombin releases factor 8 from the von Willebrand factor and helps fibrinogen split into fibrin fibers, forming the fibrin mesh, which is the sticky part of a clot that the red blood cells stick to. When factor 8 and 9 are deficient or dysfunctional, the intrinsic pathway of the coagulation cascade cannot be properly activated, thus making the clot-forming process deficient. On a cellular level, patients with hemophilia, generally A or B, will have a low red blood cell count as well as low platelet counts. Due to the severity of the disease, hemophilia affects tissues of every organ system because of its effect on a cellular level. And now we're moving on to clinical manifestations.
With hemophilia, we are concerned about bleeding. This bleeding can manifest itself in multiple different ways. Some common ways include bruising, formation of hematomas, and nosebleeds. Some more serious manifestations include things like bleeding into joints, which can be spontaneous or caused by some kind of trauma, GI bleeding, and head bleeds. Bleeding into joints can lead to chronic arthritic pain from joint damage as well as a decreased quality of life. Head bleeds can lead to permanent deficits like weakness, numbness, paralysis, dysphagia, aphasia, and death. GI bleeding can also lead to poor quality of life from potential bowel resections, ostomies, and again, death if the bleeding can't be controlled.
Healthcare providers treat this by replacing the missing proteins and clotting factors in bloods. There isn't a cure for hemophilia, but the people who do receive treatment can live just as long as people who don't have this blood disorder. Gene therapy and gene replacement therapy are potentially new ways of treating and possibly curing hemophilia. There are many treatments for bleeding disorders, and new ones are under research, so it is important to talk with your primary care physician to find the one that works best for you. Factor replacement therapies are just that, factor replacement. These therapies increase the amount of clotting factor in the blood, therefore increasing clotting and decreasing bleeding. The two types of clotting factor are plasma-derived and recombinant. Plasma-derived is made from human plasma. Recombinant factors are synthetic and made from DNA technology. The factor products use the same molecule that is naturally found in the body, or they'll use an actual human molecule from plasma. This process is called infusion and is done intravenously. The two types of factor therapies are 1, standard half-life therapy, and 2, extended half-life therapy. Standard half-life therapies treat hemophilia A and B and are done 3 times a week to daily, depending on the person. Extended half-life therapies use a molecule that delays the breakdown of factor in the body. Therefore, more factor is present in the body for longer periods of time. This will lead to less frequent infusions due to the longer-lasting clotting proteins. Extended half-life therapies are generally used for hemophilia A and B. Non-factor replacement therapies help prevent bleeding and assist in better clotting. Desmopressin is a synthetic version of vasopressin, which helps stop bleeding. This is generally used for people with mild hemophilia and can be used for joint and muscle bleeds, nose and mouth bleeds, and surgery. This therapy can be used intravenously and as a nasal spray.
Several disciplines that can help with hemophilia management are hematology. This is the study of blood and blood-forming tissues. Hematologists are medical professionals who specialize in treating blood disorders, including hemophilia. Physical therapy can help people with hemophilia strengthen their muscles and joints, which can reduce the risk of bleeding and improve mobility. Psychology, people with hemophilia may experience emotional challenges related to the condition, such as anxiety or depression. Psychologists can provide support and counseling to help them cope with these challenges. 3 nursing priorities for hemophilia include bleeding prevention by educating patients and their families about the importance of maintaining a healthy lifestyle, avoiding activities that may increase the risk of bleeding, and following their treatment plan. Pain management. Hemophilia can cause pain, especially during bleeding episodes. Nurses can help manage pain by providing appropriate pain relief medications and other interventions, such as ice packs or heat therapy. Patient education. Nurses play an important role in educating patients and their families about hemophilia, including its causes, symptoms, and treatment. They can also provide information on how to manage bleeding episodes at home and how to recognize when to seek medical attention. In 2021, almost 234,000 people were confirmed to have hemophilia worldwide. These patients can help with other side effects besides taking their medications with a proper diet and daily exercising. The patients need to also take care of any injuries or surgeries, since bleeding would be excessive. With modern medical treatments, we've extended life expectancy of hemophilia patients from 30 years to around 68 years. This also does create more problems, like chronic joint disease, cardiovascular disease, chronic kidney disease. In the United States alone, there are over 18,000 patients with hemophilia. Around 14,000 of those patients have hemophilia A, and around 4,000 of those patients have hemophilia B. With the statistics